afternoon. I'm Dr. Rupal KATHARE, and I'll be presenting our study, which is long-term anatomical and functional outcomes of myopic traction maculopathy eyes treated outside of the MTM staging system guidelines. So MTM is the result of various traction forces which are acting at the macula. The AP traction in the form of VMT, the tangential traction due to the ERM or the ILM, and the staphyloma component. So the MTM progresses in the following manner. Initially, there is myopic retinoschisis, followed by the foveal detachment, followed by myopic macular hole, and followed by macular hole RD. So the various treatment modalities, in the initial stages, we observe the patient, and the other treatment modalities for this is the pars plana vitrectomy with or without ILM peel, macula buccal, or in combination with the vitrectomy. Barbara Perulini et al. Proposed a new myopic traction maculopathy staging system, which is an OCT-based classification of the MTM, wherein they divided the MTM into 4 stages and 3 types, and provided the treatment recommendations for each of these stages. The MSS study group proposed that 8 out of the 12 varieties of the MTM required macula buccal alone or in combination with the vitrectomy for the MTM management. However, in India, the availability and cost of macular buccal pose a significant challenge in implementing this treatment protocol. Very few retina specialists in India have the training and expertise in macular buccal surgery, and most specialists prefer to perform the vitrectomy. This is the case example of a patient with a stage 3A MTM, wherein the proposed management in this stage was macular buccal according to the MSS staging system guidelines. However, in this we plan to do vitrectomy with ILM peel with C3F8 gas injection, and this shows a successful resolution of the retinoschisis along with the foveal detachment. Hence, we planned this study to study the long-term treatment outcomes of the MTM eyes, which were not treated as per the MSS guidelines. It was a retrospective study wherein the MTM cases who presented between 2012 to 2023 were studied. The MTM cases were classified and treatment plans were compared to the MSS guidelines. The MTM eyes with good quality pre-ops OCT scans with a minimum of 12-month follow-up post-surgery were included. So the following data was collected: the visual acuity pre and post-op, the pre-op OCT findings, the post-op OCT findings, the lens status, the surgery performed, and the resurgeries. The following are the results of the study. The demographics: 36 patients were included in this study who underwent the surgery, of which 16 were male and 20 were female. The mean age at presentation was 58 years, and 28 patients, 28 were right eye and 20 were left eye. Visual complaints were present in 34 eyes and were absent in 14 eyes. The mean presenting visual acuity in these patients at presentation was 0.817 logMAR units, and the following pie chart represents the lens status of the patients. The following pie chart represents the retinal OCT findings as well as the foveal contour. 27 patients had ERM, whereas there was no ERM in the 21 patients. There was a high level of agreement for the planning of the surgical intervention. However, it was seen that there was a high level of disagreement for the surgical technique of choice. Of the 30 eyes that were treated outside the MSS guidelines, 26 underwent pars plana vitrectomy with ILM peel and endotamponade, while 4 did not undergo the retina surgery. The analysis of the 26 eyes which underwent the vitrectomy: 23 of the 26 eyes underwent only the retina surgery, whereas 3 underwent cataract plus retina surgery. The following chart shows that there was a significant improvement in the visual acuity post-surgery, which was statistically significant with a p-value of 0.043. 50% of the patients showed a resolution of the retinoschisis, and 50% patients had a successful macular hole closure, and 100% of the patients showed a macular detachment resolution. Of all the patients, 26 patients, 4 patients underwent resurgeries, 3 were for rhegmatogenous RD, as well as whereas 1 patient was for macular hole RD. So these are certain case examples of the patients who were treated outside the MSS guidelines. This is a patient who presented with a stage 2A initially, which progressed to stage 3A, wherein the recommended treatment was macula buccal. However, we did the vitrectomy, and this is the post-op OCT scans. This is another patient with stage 3A with the presenting visual acuity of 6/60, and with vitrectomy, the patient improved to 6/36. However, there was a macular hole which showed a type 2 closure. This is another patient with stage 3A who presented with a visual acuity of 6/30, wherein we did a scleral imbrication along with vitrectomy. Here the patient improved to 6/18, and there was a successful resolution of the retinoschisis as well as the detachment. This is the other eye of the same patient. So in conclusion, the MTM eyes that do not follow the MSS guidelines had satisfactory anatomical as well as visual outcomes. Macula buccal is not an absolute necessary for the treatment of MTM. However, scleral imbrication could be thought of as an alternative to macula buccal, considering the cost and the limited availability of the buccal. There were certain limitations to the study. It was a retrospective study with a small sample size, and there was no comparative group wherein we could compare the treatment of these patients along with the patients who underwent the treatment according to the MSS guidelines. Thank you.
Any difficulty in surgery?
Yeah,
when you're doing a vitrectomy with such eyes, which are very long eyes, so would you like to mention that what was another reason for that?
Yeah, it could be due to the longer axial length in the patients, as well as the schisis, the vitreoschisis that is more commonly seen in patients with myopia, high myopia.
Thank you.
What was the reason for the failure, that you had some cases who failed? What was the reason for failure in those?
Resurgeries, ma'am, you're asking?
Resurgeries, yeah.
They had they had rhegmatogenous retinal detachment due to a break elsewhere. So that was not really related to the MTM surgery that was performed.
Maybe certain macular hole indices may be different in these patients.
Okay.
Thank you.
Thank you.